Chapter 31, Drugs for Coagulation. So in this PowerPoint, we're going to be talking about the different coagulation drugs and what's happening in the coagulation cascade. So hemostasis, this is involving a large number of enzymes and clotting factors. The final product is a fibrin clot that helps stop the blood loss. So the clotting process, and we're going to go right over here. There we go. So first, let's say there's a vessel injury, right? Then the vessel's going to start contracting and there's a spasm. Now the platelets come and they adhere to that injury site, and then they aggregate to form this sort of plug. And then there's this insoluble fibrin strands that is formed, and then they coagulate. So they start clotting off, so they plug it. And that's known as that coagulation cascade. Another thing interesting is typically it takes about 6 minutes for someone to clot when there's been an injury. So if you want to learn more about the coagulation cascade, you can watch this video. So anticoagulants, they're drugs that prevent blood clots by modifying different parts of the coagulation cascade. So I want you to think, which drug prevents clots by inhibiting platelet aggregation? Okay, it's a common drug that's used. So think about inhibiting platelet. So it's an antiplatelet. Just think about it. We'll talk about it in a little bit. Now, there's primary steps in fibrinolysis. Now, we have the clot removal. So first, it starts within 24 to 48 hours of the clot formation. It's initiated by the release of the tissue plasminogen activator, so TPA, which is converted to plasminogen to plasmin. Plasmin digests the fibrin strands, thus circulation is now restored. So it's a regulator, so any unwanted clots are now removed and fibrin is left in the wound. Now, some diseases of hemostasis, it could be thromboembolic disorders, such as a thrombi or emboli, and then thrombocytopenia, not enough platelets. Bleeding disorders like hemophilia. Some lab tests to measure coagulation. There's multiple lab tests that we can do. So they're used to diagnose and treating coagulation disorders, so such as activated clotting time. We have our PT or prothrombin time, our INR, we have our thrombin time, activated partial thromboplastin time, our APTT, we have our LFTs, our bleeding time, our platelet count. Now for the activated clotting time, okay, it's used to monitor high dose of heparin. Okay, it can be used for before, during, or after surgery or any medical procedures. Any high values will indicate a risk for bleeding, and the heparin dose should be reduced. Now, the normal values here, it varies per patient because we have this big range, 70 to 80 seconds. Now, what does this even mean? 70 to 180 seconds. What does this range even mean? What do these numbers mean? This time is telling us how long it takes for a clot to form. So, for example here, 400 to 500 seconds during coronary bypass surgery. That's how long it takes for a clot to form. Then we have our APTT, activated partial thromboplastin time. So that's again used for heparin, and typically it should be 25 to 35 seconds, and it should be 1.5 to 2 times higher than the pre-treatment values. Again, high values indicate a risk for bleeding. Our bleeding time, okay, normal just for general diagnosis of coagulation disorders. It should be about 2 to 9 minutes, okay, on the forearm. Long bleeding times may indicate a low platelet or if they're on an anticoagulant therapy. Now there's heparin anti-XA, which is used to monitor heparin or low molecular weight heparin. That's especially used for if they have a PE or a DVT. Now we have our normal values, and then again, high risk for bleeding if there's high values. Our platelet count, okay, so there's our values. It's about 150,000 to 350,000. The values below 50,000 indicate thrombocytopenia. Okay, that's a condition where you're going to have low platelet count. So platelets, they're colorless blood cells that help you clot. They help stop the bleeding by clumping and forming those clots in the blood vessels that are injured. We have the the prothrombin time, which is our PT. That's going to help monitor our warfarin therapy along with our INR. So normal values should be 2 to 3 to prevent a DVT, 2.5 to 3.5 is to prevent any arterial thrombus. Thrombin time is to assess the fibrogen deficiency, so really to see the effectiveness of the heparin therapy. We want it to be 13 to 15 seconds. Now again, prolonged values may occur if they're on heparin. So actions of coagulation modifiers, anticoagulants. They inhibit the clotting factors preventing thrombus growth. We have antiplatelets. They inhibit the platelet action, preventing a thrombi growth. Then we have thrombolytics. They're dissolving the existing thrombi. We have hemostatics. They're inhibiting the fibrinolysis, promoting the clot stability. Now we have our anticoagulants. We have heparin, which can be given sub-Q or IV, so parenteral, or warfarin. Warfarin will be given oral. Now again, warfarin, what lab values are you going to be monitoring? PT and INR. Heparin, what lab values are you going to be monitoring? Most likely you're going to be looking at the APTT. So for our heparin is going to be used for DVTs, any blood clots. It's really to prevent the existing clot from enlarging anymore or forming any new ones. Now keep in mind, it's an anticoagulant. It's not thrombolytic. It's not going to dissolve any existing clots. So any high doses are to treat conditions like an immediate anticoagulation if necessary, such as a DVT or a PE. Heparin is now poorly absorbed by the GI tract, the GI mucosa, because of the rapid metabolism by the hepatic enzyme. Now, it can be given either subcutaneous or IV injection, which can be a continuous infusion. Now, like we talked about, if you're giving an IV, it's going to be weight-based. They're going to be looking at the APTT value. They're going to be looking at the patient's weight, and that's how they're going to calculate how much heparin they can be giving. Now, when you're in the hospital setting, they'll have a protocol where you and another nurse are going to have to do a double check on this and make sure there's no medication errors. Now, you'll never want to give this IM. It's contraindicated due to the bleeding risk. Adverse effects. Abnormal bleeding can occur during the heparin therapy, especially if it's IV. It can occur fairly quickly. Now, what type of abnormal bleeding? How about petechiae? It looks like a rash. It's usually caused by bleeding underneath the skin. There's one way to tell the difference. Is by pressing on the spots. They could be raised and they could be flat, but another thing is these are very unique. They're usually red. Sometimes they look a little like reddish purple depending on the skin tone, but they won't be itching and they won't be painful. This is what they'll look like on someone who's Caucasian, but again, if they're more fair, a little bit darker tone, they could have that purplish tint. Now, heparin should not be administered with anyone who has any active internal bleeding, severe hypertension, or if they have any type of bleeding whatsoever. You're going to be giving this, again, IV or subcutaneous, but you don't want to give it with any oral anticoagulants such as warfarin because, again, it's if you give it to a patient who has already taken an anticoagulant, they're at risk for increased bleeding. Now, drugs that inhibit the platelet aggregation, such as aspirin, can also induce bleeding. Now, when we're talking about warfarin, this is a vitamin K antagonist. Now, in class, you guys already told me if someone has a high INR or PT, give them vitamin K, especially if they're on warfarin, because it's going to help them clot. Now, indications for giving warfarin, it's to prevent stroke, MI, DVT, PE, especially if someone's undergoing like a hip or knee surgery. Another thing is with this, it can be very life-threatening. Okay, if bleeding occurs during the therapy, it should be reduced than the amount of warfarin that they're going to be given. And possibly they may have to get vitamin K. The most serious adverse effect is abnormal bleeding. The anticoagulant activity of warfarin may persist for up to 10 days. It could cause major fatal bleeding, and regular monitoring of their INR is required. They could be getting their INR checked weekly, and even more. So anticoagulants, really most serious side effect is bleeding. You want to monitor those CBCs, lumbar pain, abnormal bulging, or abnormal abdominal bulging, a guaiac test on the stool. If they're having a transition from heparin to warfarin, there's an increased risk of bleeding. Don't give warfarin to pregnant patients. You can give low molecular weight heparin to pregnant patients. You're gonna want to monitor those intake of vitamin K rich foods such as green leafy vegetables. Limit their intake of garlic as well if they're on anticoagulants. And then we have antiplatelets. So our antiplatelet drug is what? Okay, antiplatelet drugs, they're prolonging that bleeding time. Okay, altering that plasma membrane of the platelets so they cannot aggregate. This is aspirin. Okay, it's to prevent thrombi formation after stroke or an MI. There's other ones, but we just won't be going into those today. So another antiplatelet drug will be Plavix. Okay, it's indicated for the prevention of thromboembolic events in patients who recently just had a stroke, an MI, or if they have PAD. They're going to be given tablets, okay, and they should not be crushed or split. For this medication prolongs the bleeding time by inhibiting that platelet aggregation, directly inhibiting the ADP binding to its receptor. The binding of this is irreversible, and the platelet will be affected for the remainder of its lifespan. If a patient is going to go for surgery, they need to discontinue this medication for at least 5 days prior to surgery. It's generally well tolerated, but there are some symptoms your patient may complain of, such as flu-like symptoms, headache, dizziness, bruising, rash. Contraindications is a patient who is actively bleeding. Anticoagulants and other antiplatelet agents, such as NSAIDs or NSAIDs, aspirin, they increase the risk of bleeding and they should not be given. They're contraindicated. Lab tests, they prolong the bleeding time, so you want to monitor the bleeding time. Now, when you're giving antiplatelet agents, you're going to want to monitor for bleeding. Risk is increased if giving with anticoagulants. Prolonged pressure needed for control bleeding at puncture sites. And then monitor for that GI upset, especially if they're taking warfarin. And then also, you want to monitor those females who are having menstrual cycles. If they're having abnormal or increased menstrual bleeding, this is a concern. And then this is a graph here, so you can see how much aspirin typically they would be given. Typically, your patients will be taking a baby aspirin if they're on aspirin for antiplatelet, and it'll be about an 81 milligrams per day, but they can take 650 BID as well.